It's on the BC Renal website. Next slide. We're coming to you today from the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, the Tsleil-Waututh nations, as well as the Métis Chartered community of the Lower Mainland. And we reflect, as always, on how we can improve care and understanding of our First Nations peoples and attempt to undo many of the injustices that have occurred, especially in the healthcare system. So I remind all of us as we do our work on a daily basis, both clinically and otherwise, to think and reflect on ways to improve those interactions. Next slide. Province-wide rounds, as you know, is a collaboration between the University of British Columbia Division of Nephrology and BC Renal. There are a number of different industry partners that we thank, as well as all of you in the health authorities who contribute both in content as well as in implementation of the knowledge that we gain here. So thank you all for that. And it gives me a lot of pleasure to be able to introduce our three speakers. Dr. Sheldon Tobe is an internist and nephrologist at the University of Toronto, based at Sunnybrook. He's a professor of medicine at U of T and at the Northern Ontario School of Medicine, where he's a Heart and Stroke Foundation Chair of Aboriginal and Rural Health Research. He was chair of the Canadian Hypertension Education Program from 2008 to 2012, and on the board of directors of Hypertension Canada, and he remains co-chair of the Canadian Cardiovascular Guidelines endeavor called C-Change. In 2023, Dr. Tobe was asked to lead a process to create a new brain-heart clinical practice guideline to fit within C-Change, and was able to get peer-reviewed funding from the Brain-Heart Interconnective Program, which is really quite a feat. He also serves on the board of directors for the American Society of Hypertension Specialists and has ongoing peer-reviewed funding and has received many teaching awards and other distinctions. And we also are pleased to welcome Dr. Syed Amin, who is a clinical assistant professor of medicine at the University of British Columbia and a staff nephrologist at St. Paul's Hospital. He completed his nephrology training in home dialysis and hypertension in Ottawa and is part of the division since August of 2023. And Dr. Jesse Bittman is a general internist in Vancouver whose focus is on hypertension and obesity medicine. He completed training in diagnosis and management of resistant hypertension at UBC and U of T, and is also on the C-Change and Hypertension Canadian Guidelines Committee. In 2022, after he'd been at the hypertension clinic at St. Paul's for 5 years, he started a multidisciplinary clinic at the Revolution Medical Center. And he's also involved in research looking at improving the care of people who come to the emergency room with hypertensive urgency. So with that, we have a cast of outstanding and well-respected individuals. So I'll turn it over to you guys to tell us what's new about hypertension and renal denervation and ongoing and continued conversation amongst everybody. So over to you guys.
Thanks, Adira. That was really great, and it's a privilege to be here with everyone and to talk to so many friends in BC this morning. Let me share my screen. Share. And each of the three of us have our own slides, so I'll take you through the first part. Oops. With the beginning. There we go. And it's great. All three of us are hypertension specialists. And Vancouver, I must say, has the greatest number of hypertension specialists per population in the country. And that's thanks to Nadia Khan, who has really been a driver for hypertension. So our learning objectives today are to describe RDN, renal nerve denervation, and the evidence for safety and efficacy, describe patient preference and shared decision-making for RDN. Many of you are going to be saying, well, what's this renal nerve denervation? Didn't it get tried in the early 2000s and it failed? How come it's back again? So I'll explain. Here are my disclosures. Here are Obaid's disclosures. And here are Jesse's disclosures. Okay, some quick facts about hypertension. It's highly prevalent. And globally, lots and lots of folks have hypertension. Canada, actually, 25% of our population is hypertensive, and yet worldwide, it's more like 30% plus. And despite the availability of effective medications for treatment, it's still a leading global cause of death and disability. It's a chronic disease. And the last line is now out of date. We do have new drugs that are soon to be coming out. In particular, the aldosterone synthase inhibitors are closest. So there's going to be some excitement and new therapies for us. Does blood pressure lowering work? Yes. Here's the BP. The blood pressure lowering treatment trial is collaboration, 1/3 patients from a host of clinical trials, demonstrating that lowering blood pressure by 5 millimeters of mercury leads to improvements of outcome. 5 millimeters of mercury gives you a 10% reduction of major cardiovascular events. And I'll give you some breakdown on those numbers in a sec. Just in case you forgot, blood pressure is the amount of force on the walls of the arteries as the blood circulates around the body. And in that blood pressure lowering treatment trial is collaboration. 4 years of follow-up, just a 5 millimeter drop in systolic blood pressure leads to a 13% reduction of stroke, 13% reduction of heart failure, 8% reduction of MI, and cardiovascular death by 5%. And the more we lower blood pressure from the higher up, the better the results. And those benefits really are very, very broad-based. So how are we doing in Canada? Canada was the leader in the world for blood pressure awareness, treatment, and control. And so we were just almost at 2/3, 65%. You can see Canadian men, Canadian women in 2007 to 2015. But that number is starting to fall off in the latest review up to 2017. This is pre-pandemic. And unfortunately, it largely seems to be falling in women. We don't know why that is, but it's of concern. The Americans have seen the same thing. So we need to do more. We need to do better. We've published on that, and it may have something to do with the Public Health Agency no longer working with our organization, but we're all hands on deck to try to improve things. And we've now ceded the world's best blood pressure control to California with Kaiser Permanente doing better than we are. Okay, renal nerve denervation. Why is it different now? So you may recall the Simplicity 3 hypertension study, and it was a treatment versus sham. It did not show a significant blood pressure reduction. Now, there was methodology problems with that study. Patients got into the study with, quotes, resistant hypertension, but they really didn't. They just wanted to be in it. Some patients were there not taking their medications, no surprise. And unfortunately, there was no safety signal found. There's no efficacy from that. The technology wasn't as advanced as it has become. And as I mentioned, patient selection, they did not have to go through a hypertension specialist, for example, to get into that study. Most significantly for us is that 10 years later, there is no concerning safety signal coming from the patients in the treatment arm. So what do we have today for renal nerve denervation? There are 3 technologies. Radiofrequency ablation, that's the one that's available in Canada. And now the spiral one has electrodes, typically 4 of them in a spiral, and they're about 6 millimeters apart. There's ultrasound, that's the radiance. It is not available in Canada. And neurotoxins, which it's definitely not available in Canada. It's kind of a weird thing where you put needles into the artery and inject neurotoxins into the perivascular space. Anyway, Canada, the radiofrequency the spiral technique is available in Canada and approved. And does it work? So Obaid's going to talk about this more, but it does work. And the newer studies in the last decade demonstrate that there is a reduction of blood pressure. The sham is in the dark color. The active is in the sort of light pinky color. And to the right of 0 is blood pressure reduction. And on your left is office blood pressure. On your right is ambulatory blood pressure. And in these 4 randomized controlled studies of both radiofrequency and ultrasound, you can see that there is a nice reduction of blood pressure. And this is a nice summary paper from Ray Townsend that came out in one of our journals that really nicely summarizes both procedures. And Obaid will get into these more. This is what the catheter looks like. You can see the spiral and the little electrodes on it. At the recent CCS of Vancouver, I got to sit through a lecture on ablation. So I actually know what these words mean, the radio frequency energy, the energy penetrating the wall, and so on. It's an hour of my time I will never get back again. I sat there with a bunch of cardiologists. So what's new? The electrode design is designed to give consistent ablation. Now we're going not just in the main renal artery, but in the distal renal artery and the branches. That's where the nerves are, as I'll show you in a sec. And we know, and the nerves are much closer to the vessel there. Finally, animal studies were done, which had not been done in the previous cycle in the late 90s and early 2000s. So here's a schematic, and this has been enhanced, but it shows that the renal nerves, as you get up into the renal artery, are much closer to the artery than as you get closer to the aorta, and the nerves are all at different levels. Now we're both picking up the afferents and the efferents when we do denervation. And so I'll finish with the rationale for RDN is to reduce factors that maintain and cause progression of hypertension, interrupt the activity of afferent and efferent sympathetic nerves, and reduce the sympathetic nervous system's influence on the renal vascular resistance and renin release. I think that's it. So I will stop sharing and hand over to Obaid.
I think I'm gonna jump. Was I gonna jump in with a case, or was we gonna do that after?
Oh, sorry. My apologies, Jesse.
Yes, yeah.
I totally got it mixed up. Yes, sorry, Jesse. We're jumping over to you and the case.
There we go.
I got texted from the dialysis unit that just threw me off.
Perfect. You guys should see my slides, right?
Yep.
Perfect. So I'm going to talk about 2 patients, one who had RDN and one who didn't. So we'll start with the patient who had.
Jesse,
yep.
Can you hit the screen? Yeah, the big. There you go.
There we go. Not better.
Perfect.
Okay. So first patient who had renal denervation. She is a 54-year-old woman with very resistant hypertension. Lots of possible reasons. She has sleep apnea, presumably using her CPAP. She, I think, has PA, but she's been on spironolactone since I first met her, so I never actually did the testing. She's on medications that can raise blood pressure. She had bariatric surgery in the past, Dr. Cleater special, so I'm not sure if she's absorbing her medications. And dexapressin, metanephrine, catecholamine, and CT renal angiogram were negative. She is on about every blood pressure medication that I know. And I spoke with her pharmacist about, first of all, she's got them blister packs, she's picking them up on time, she's adamant she takes them. We changed them over to the things that are most likely to be absorbed. There's some evidence that she's taking them. Her potassium did go up when I increased her spironolactone. Her heart rate has never come down despite being on verapamil and metoprolol. So some questions. I did do a direct observed therapy, and I couldn't really interpret the results that well for various reasons. And so we offered to, I would discuss with her having renal denervation as sort of a last hope. And I guess I didn't mention her baseline blood pressure was, despite all those medications, was still around 200. And never, it came down from maybe 220 to lower 200s with medications. So you can see it was pretty consistently around that 200 over, 120 to 130 mark. She had her renal denervation in February 2023, and her blood pressure started decreasing after that. About 3-4 months later, her blood pressure had dropped by about 20 points down to around 180 systolic. And now a patient that will actually be familiar to some of you guys because he's actually is known to the St. Paul's Clinic, a 62-year-old man who he's the one who keeps me up at night because about 5 years ago, he actually asked me if he should go to Europe to have renal denervation. And at that time I said no. And he had persistently elevated blood pressure around 150 on a couple medications, but intolerant to everything else. I've cycled through things, always starts it, gets a side effect, some typical, some less typical, and would stop it. And then we would sort of be back where we started. And it sat on my to-do list to talk to him about whether I could get him into RDN until he had his hemorrhagic stroke. And was admitted to hospital for a number of months with that. So those are my two sort of cases to get thinking about where this might fit in. I can hand it over to Obaid now.
Perfect. Thank you, Jesse. So in the next 15-20 minutes, I'll attempt to go through the literature a little bit more in detail. So thanks for having me. Again, we know that hypertension is a quite a complex entity, and this was described over 67 years ago by Dr. Paget in the mosaic theory of hypertension, where there's nerve participation, cardiovascular, and we know over the last couple of decades that there's other factors that play into this sort of framework of hypertension, understanding the complexity of hypertension. Where renal denervation comes into play is the sympathetic nervous system, predominantly in the kidneys, is quite prevalent and quite active in patients with hypertension. So the renal sympathetic nervous system comprises of both the efferent and the afferent nerve fibers. The efferent nerve fibers run from the hypothalamus to the kidneys along sort of the sympathetic ganglion between T10 and L2. Activation of the sympathetic efferent nerves increases renin release to activate the further cascade or RAS pathway, which increases sodium reabsorption. So the thought is that renal denervation affects both the efferent and the afferent. The afferent nerve fibers go from the renal pelvis and are activated and have chemo and baroreceptors that upon stimulation from either ischemia or urea toxins sort of trigger activation of the renal efferent nerve pathways. Renal denervation is thought to interrupt both the efferent and the afferent, and there's a lot more data to suggest that efferent nerve fibers do play a pretty significant role in RAS activation and renin release. As has previously been mentioned, Dr. Tobe had mentioned that some of the issues with the initial RDN trials were the technique. And over the last decade, the technique has improved. And this is predominantly due to a postmortem study that indicated that the highest average number of nerves were observed in the proximal and the middle segments of the renal arteries, and lowest in the distal segment. However, the nerves were closest to the lumen in the distal regions of the renal artery. So what they found was that 70% of the nerves were located within 2.5 millimeters of the vessel wall, which obviously allowed for easier access for RDN and probably had some implications on why the other trials did not show a positive outcome, specifically Simplicity Hypertension 3. So this is just a quick review of some of the landmark hypertension trials in RDN. Again, RDN first was reported in a case report at about 2007 or 2009, where there was significant improvement in blood pressure about 12 months. This was followed by an open label single arm prospective trial, which is Hypertension 1, Simplicity. Randomized but not blinded was a Simplicity 2 trial, and both of them demonstrated good improvement in blood pressure. And I should note that office blood pressure was measured in these two trials. And both of these trials had monoelectrode radiofrequency catheters, which were the first generation catheters. This quickly moved to the Simplicity Hypertension 3, which was a randomized control trial, looking at about 500 patients with uncontrolled hypertension and looking at their 24-hour ABPMs. As Dr. Tobe mentioned previously, that the Simplicity Hypertension 3 trial did not show any significant difference in their primary outcome, which was 24-hour ambulatory systolic blood pressure. However, again, even with that study, there were some methodological issues, including, there was changes in the patients taking the medications, some of the limited operator experience with the catheter ablation, and it was thought that maybe only a small percentage of patients who had renal denervation actually had complete circumferential ablation in the main renal arteries. And again, the Simplicity 3 hypertension did not actually focus or target the branch vessels, which are quite important in the other trials. Because of this, the Hypertension 3 trial, there was a bit of a 4 to 5 year delay in doing further studies. And renal denervation had already been approved prior to this in Europe, but because of this, the FDA had not approved renal denervation. Then we had the spiral hypertension off trial and on trial, which were more pilot studies to look at the feasibility and the efficacy and the safety performance of these studies. Both the spiral hypertension off and on had about 80-odd patients, which looked at reduction in 24-hour ABPM. And in the hypertension off study, they did find that there was a significant reduction in blood pressure for 24-hour ambulatory monitor of about 3.9 in the renal denervation arm. From there, we had longer expansion studies, and I'll talk about some of them. I do want to mention, as Dr. Tobe mentioned, as previously outlined, that there are 3 techniques, and the one that's approved in Canada is the multi-electrode radiofrequency one. There's also the Paradise system, which is an ultrasound one, and also the dehydrated alcohol, which is not approved in Canada as of yet. But the ultrasound one studies Radiance, Solo, and Trio, which I'll sort of discuss towards the end of my presentation. So from the hypertension off medications, they expanded this study further in 2020 from about 80 patients to 320 odd patients. This is the inclusion criteria looking at patients who are not on any medications. So sort of outlining, the importance of how blood pressure reduction can happen with renal denervation in patients who are not on any blood pressure medications. Again, they looked at patients whose GFR were above 45 and did not have other causes of hypertension. This is the baseline characteristics of patients who are not on medications. Mean average blood pressure was about 150 systolic and about 98 diastolic. And what they found was, patients at 3 months, there's a bit of a short-term follow-up. At 3 months, they had a reduction of about 4 in the patients who did have renal denervation, and this was seen on the ABPM, This was consistent along blood pressure in the office and also diastolic blood pressure. One of the things that we'll notice in most of the studies when we review the studies for renal denervation is this concept of it always being on and the continuous nature of the therapy, which is obviously quite important. As we know, the pharmacokinetic profile, some of the medication that our patients are on have short durations of actions, let alone adherence concerns. And renal denervation really allows for this ability to be on 24 hours a day. And there are studies to suggest that nocturnal hypertension and lack of nocturnal dipping actually have positive cardiovascular impacts on patients. And renal denervation really allows for reduction of this blood pressure across the board for 24 hours. So this is seen in most of the studies. This study that I chose was predominantly looking at patients who were off medication, that there was this consistent reduction in blood pressure throughout the day. The hypertension on pilot study was also a feasibility study. Again, these were patients randomized on either 1, 2, or 3 antihypertensives for 6 weeks, and then they were randomized and followed for about 6 months, and then longer duration was 3 years. At 6 months, there was a significant reduction in blood pressure with patients who were on antihypertensives, and the primary outcome, which was 24-hour ABPM of about 7.4. Of note, the medication burden between the two arms was not significantly different. The patients who underwent renal denervation had about a 3.5, and sham was 2.9 at 6 months, so relatively similar medication burden. They further went on to do a longer and also an expanded cohort from the pilot study, which was published last year. And this was again looking at the same patients who were on medications and looking at the 24-hour ambulatory monitor, and they were randomized either to sham and also to renal denervation with medications. And one of the things that's important in the study is this was done between 2015 and 2022, and we know in 2020 and onwards, that we obviously had the COVID pandemic, which limited some of the abilities of this study. The medications and the baseline characteristics were very similar. So the patients were on about 1.8 medications at baseline. The baseline GFR was about 80. Which actually did not change much after 6 months. What they did was they found that the renal denervation patients had about total ablations about 47 per patient, and the catheter time was about 54 minutes, and the contrast volume was about 200 cc's, and that's not data that's shown on the slide. The outcome, unfortunately, because of the COVID pandemic and some of the protocol deviations due to the COVID pandemic and some of the restrictions, the primary outcome was not significant. However, their secondary outcomes looking at both office blood pressure and nocturnal blood pressure were significant, and there was some good reduction in their office and daytime systolic blood pressure. From the pilot on study, they decided to do a longer 3-year follow-up and found that there was sustained reduction in blood pressure across the board. So in patients who are on medication, whether it was 1, 2, or 3, at 36 months, they had sustained reduction in the blood pressure of upwards of about 10, which is 2 antihypertensives for a lot of patients. The amount of medications were similar at about 3 years. And this was, consistent in both office and nighttime blood pressure. What they also found was 40% of the patients who underwent renal denervation had systolic blood pressure less than 130 or at 36 months versus 25% in sham. And really, that 15% difference of getting patients to target is quite significant and allows and gives our patient options to be able to meet our blood pressure thresholds and targets. Safety is always something that's brought up when we discussed renal denervation. This was at 36 months. There was really no safety signal to suggest that patients who underwent renal denervation had either renal artery stenosis or dissection or other vascular complications. Similarly, there was really no renal injury related to the renal denervation at about 3-year follow-up. So there is a global simplicity registry which looks at real-life registry of patients, and to date they have about 3,000 patients, and they've sort of risk stratified these patients on their registry for high risk elderly, atrial fibrillation, high cardiovascular risk, and resistant hypertension, and then they put out some data looking at this on the registry with their full cohort, showing patients who are within that registry had an office blood pressure about 166, 24-hour systolic blood pressure was about 150. A lot of these patients within the registry were on almost 5 antihypertensives. So we're really looking at some of the high-risk patients that we often see in our, whether it's nephrology clinic or internal medicine clinic from a clinical standpoint. These patients were then placed into subgroups. So this is the baseline characteristics of some of the simplicity registry. And again, CKD, was defined as GFR below 60. A lot of the studies that have been done had a cutoff of about 40 to 45 for GFR. But we can see across the board, in diabetics, resistant hypertension, that these are sort of the high-risk patients. And incredibly, when they looked at blood pressure reduction in this high-risk population at 3 years, there was significant reduction in blood pressure in resistant hypertension, in diabetes, in patients with CKD, and other high-risk cardiovascular, high-risk patients. A 23-point reduction in blood pressure for patients with resistant hypertension is quite substantial, and we know that a lot of the patients were on 4 to 5 antihypertensives. Again, this is looking at blood pressure reductions at 3 years and consistently from 6 months to 3 years in patients who are either on 1, 3, 4, or more than 5 antihypertensives. Again, this is a very high-risk population, and if you look at patients on 1 or 2 antihypertensives, there was a 20-point reduction in their blood pressure. Similarly, at 3 years in patients on 4 medications had an 18-point reduction in office blood pressure and 15 when we look at the ones that are on 5 antihypertensives. So that was a brief summary of some of the simplicity and the spiral studies, which was a radiofrequency. I quickly wanted to talk about the Radiance trials, which is the ultrasound one that's not approved in Canada. So they had 3 studies, including Solo, Trio, and Radiance. Solo was either Solo was off medications, similar to Radiance 2. Trio was on 3 antihypertensives, including your RAS blockade, diuretics, and a calcium channel blocker. In the Solo study, patients were taken off medication, and they saw that there was a 6.3 reduction in blood pressure in patients who underwent renal denervation at about 3 months. Similarly, in the Trio, there was 4.5 millimoles of mercury reduction in patients who underwent renal denervation at about 2 months. In Radiance, which was probably one of the Radiance 2, which was one of their larger trials published last year, did show that there was a 6.3 reduction in systolic daytime ambulatory monitor blood pressure. They've pulled the Radiance trial data into this nice summary. Again, very significant, consistent blood pressure reductions across the board. On longer-term follow-up, there was similar reduction in blood pressure at about 36 months. Looking at office blood pressure, there was a reduction at about 8 in patients who underwent renal denervation and were on average about 3.5 antihypertensives. So put this slide up to sort of summarize a lot of the sham-controlled RCTs that have been done over the last 7 to 8 years, looking at different techniques. And again, as we can see, that regardless of the technique and the device used, regardless of whether patients are on antihypertensives or are not on antihypertensives, there is a good reduction in blood pressure in patients who undergo renal denervation. This was seen on short-term follow-up and also at about 36 months. Again, no talk is complete without putting up a forest plot. This was a recent meta-analysis that was published this year, which combined and looked at the 16 randomized controlled trials that we have in renal denervations, and there's a few more that have been published over the last several months, and really found that at 24, the blood pressure reduction at 24-hour ABPM was about 3.6 within their meta-analyses. This is shown on the left diagram. Similarly, when they looked at the subgroups for patients who are on antihypertensives and not on antihypertensives, they did find that there was a similar improvement in treatment in those patients along with those with resistant hypertension.
How well everybody knows, period.
So summary, Medtronic was spiral radiofrequency was approved by Health Canada earlier this year, and is currently being used across multiple centers in Canada and the US, including our center at St. Paul's in VGH. Again, renal denervation provides a significant, safe, and sustained reduction in blood pressure. And I note that irrespective of the technique, irrespective of their baseline antihypertensives, I didn't show some of this data due to time constraints, but when they look at the types of antihypertensives, including aldosterone antagonists, regardless of the type of medication that patients are on, there's still an improvement in blood pressure with patients who undergo renal denervation. Blood pressure reduction has been seen in many subgroups based on the global registry. Again, this is a registry and not a randomized controlled trial, so it's observational single-arm data looking at high-risk patients with CKD atrial fibrillation and found that there was good reduction. Again, renal denervation, as opposed to some of our antihypertensives that we have, is always on. Fortunately, to date, there has been really no significant signal for harm that we worried about, and has been quite well tolerated based on some of the long-term data that we have. Thank you, and I'll pass it over to Dr. Tobe.
Thanks, Obaid. That was terrific. And we're going to have lots of time left for Q&A. And I see that Lindsay Khan is on the call, so that is fantastic. And please get ready to answer some questions with us. So I see there's been some technical questions that you would be much better to answer than any of us non-interventionalists. Okay, I'll just pick it up the last few slides. Oh, come on. There we go. So this one is our approach at Sunnybrook when we're bringing in a patient for the intake. They come in through the hypertension specialist, procedural planning with the interventional team, informed consent we're still doing with each patient. They get the procedure and then they follow up in my office. And the CTA is really important to look at the renal arteries, and I'll let Lindsay comment on what his practice is. We want to rule out fibromuscular dysplasia, renal artery stenosis, make sure that the vessel size is okay. And as well, we're ruling out secondary hypertension. So much adrenal hypertension in this group, and you really don't want to do RDN in patients who have adrenal hypertension as the cause of their hypertension. There was a comment before about renal artery stenosis as a result of RDN, and really there is no signal long-term that has been seen, which is really encouraging. Then we follow up our patients. Okay, so the big question is, who is this for? Is this for everyone with hypertension? And the answer is a definitive no. So one of the ways to approach it is to say, how well are we doing at managing hypertension? I run a hypertension clinic and I do pretty well. And my data is that I'm at around 90% treatment and control for the patients in my clinic. But that's not 100%. So think about your own patients in your own clinics. And I'm quite sure that none of you have 100% of your patients under control. So the question is, why is that? And some patients just can't take medications. There's now a recognized condition for multiple drug sensitivity, whatever it is that's causing that, is responsible in large part for the blood pressure not coming under control. Maybe patients just don't want to take them, but they're still going to have high blood pressure. It's going to be uncontrolled. They're going to get into all sorts of trouble over time if their blood pressure isn't lowered. So we also, of course, want to hear the patient's voice in this. It's important to understand the patient's preferences and values, and look at patients perhaps who have the greatest risk. Younger patients who are going to have their hypertension the longest, who are going to be in and out of our healthcare system if they don't bring their blood pressure under control. Of course, we want to rule out white coat hypertension. So when I was in Vancouver for the CCS meeting, many of you were away at the ASN at that time, but we organized through CHESS a great session, and we had Dr. Block come up and talk about renal nerve denervation, and he talked about an approach where patients who have blood pressure that is uncontrolled on medication, and then we're telling them, we're going to have to increase your medication number. We're going to have to increase the dosage. And as an alternative to that, they could look at renal nerve denervation instead of adding ever more medications onto their regimen. So that is an approach I really like, rather than patients having the expectation that they're going to be able to come off all their medications, which is really not the case. So I'll end there, and we have lots of time for Q&A.
Yeah, no, great. Thank you all. And apologize to those of you who heard my brief unmuted thing that happened. There are some questions in the chat, but maybe just for context, where's this procedure being done in Canada at the moment, or specifically in BC, since we have a BC audience? That would be a good place to start.
So I'll give a generalized view of that. Right now it's being done in major centers where and it's always been matched up with a hypertension specialist. And that's been the goal of CHESS, is to ensure that where it's being done, it's being done properly in accordance with as many guidelines as we do have. And I'll defer to Obaid and to Jesse for BC. And Lindsay.
At the moment, at least in BC, it's being done at VGH by Dr. Lindsay Mackin and his colleagues. And hopefully over the next little while, with time and more patients, and the hope is to have sort of centers where this can be performed across the province. But as it stands, it's only being done at VGH, and Dr. Mackin, who I see is on the call, is the one that's doing it.
And then there's a question about regeneration of nerves after ablation, which I believe Lindsay answered, but maybe Sheldon, you had also wanted to answer it live. What's the risk? The risk of arterial stenosis has always come up a number of times.
Yeah, so arterial stenosis just doesn't. There's precious little side effects. We're all worried about renal artery stenosis. Just hasn't materialized. Will the patients without renal nerves suddenly have drops in their blood pressure, leading them to have more syncope? Hasn't occurred. And the question about regenerating nerves, I had no idea about. So I'm pleased that Lindsay put an answer in there to help us with that.
Yeah, I guess we talk I'm just looking at there are other questions. Yeah, there are. Hold on. Lindsay answered a few things. Lindsay, do you want to maybe, if you put up your hand, we can unmute you, and then you can sort of give a little short dissertation on the things that you're answering. Thank you. So Sidoni, if you admit, there you go. There you have it. Welcome, Lindsay.
Hi, can you hear me?
Yep.
Yeah, good morning. Yeah, so far, yes, we're only doing this at the radiology department at VGH, although our hope is that it does spread more broadly. We are collaborating with hypertension specialists and only taking patients to date from hypertension specialists. So when they get referred, we do a Zoom or phone consult with the patient, go through the procedure, and then book them in. Mostly as a daycare procedure, it's under intravenous sedation unless they are previously pain sensitized. We do occasionally get some patients with loin pain hematuria syndrome, some of whom have been hypertension and they're pain sensitized. So those ones we would do under GA. Otherwise, it's just a short stay daycare procedure under intravenous sedation. The question always comes up is who is the optimal patient, and we haven't defined that as yet. Some of the ones that we've seen who seem to do well are those either with very, very high office systolic pressures or patients who are intolerant or not taking or not compliant with medication. Seem to be ones so far that are doing well. From our point of view, from an interventional radiology point of view, it's a technically simple, straightforward procedure. It's the management of the patients that's a little more complex.
Super helpful. And a related question, I guess, which probably is important from the healthcare system perspective, is that the catheters are expensive, and how is this treatment funded? Like, do we have to get special approval from someone to get this done in BC at the moment?
No, thankfully, well, it's been a slow trickle so far. I think if we truly, if this seems to fit within the Canadian context, as it does seem to so far, then yes, I do believe, Adira, we will have to get special funding. Right now, our department, we've applied to our department and got funding within our hospital department radiology budget for disposables. These are expensive disposables, and so we've addressed with Medtronic that if this goes on a broader scale, we will have to somehow revisit that.
Right. And I guess one of my questions, just from a provincial perspective and equity and other things, does anybody have a sense of, Sheldon, your points about it's a shared decision making, it's not for everybody. However, if one was to use some very simple or something that would be non-contestable, does anyone have a sense in the province, Jesse or Obaid, like what are proportion of people who may benefit from this procedure is? Also in the context of the fact that we now have disease-modifying antihypertensive agents like the non-steroidal MRAs and ASIs coming down the pipe. So it's two questions really. One is, do we have an environmental scan of the potential number of people who might benefit from this? Because that would also help Lindsay with his business case to have to make. But also, the second question is, how are we fitting in some of these other agents in those same people? So I guess it's a question for the panel.
So, Dira, I don't have a sense of the need across the province for patients who are followed at various hypertension clinics. And, it's a good point. It's probably something worth exploring. As you know, there are multiple hypertension clinics, just in the Lower Mainland, including St. Paul's VGH and further on. So, I think there are probably more patients than what we think that would probably benefit from RDN. And again, it doesn't take away from the fact that these patients still need to be on antihypertensives, whether it's 1, 2, or 3. but that effect long term is sustained when they do get renal denervation. So, regardless of the class of medications, and obviously we have a lot of new classes that we're seeing. I think that effect probably will still be there, and specifically in those patients that we do think are non-compliant with a lot of their medications, and compliance on a good day is about 40 to 50% on most of our patients, and even in the studies was about 60%. So I think the medication is still important, it's just an added layer.
Great. Jesse?
So I don't have a great sense of the numbers either, but I did want to just highlight what you said about the disease modifying agents, and that's where it fits in for me is there is not evidence for outcomes with this yet, right? So obviously we're choosing our agents with disease modifying, with outcomes evidence, and then the question comes in, you're either on or not tolerating or have a contraindication to your calcium channel blocker, your diuretic, your ACE or ARB, your maybe MRA, depending on how you feel about the evidence on that, and then your so then where does it fit in before we're going to alpha blockers and hydralazine and things that just simply don't have evidence and we know are poorly tolerated, right? So
Right.
when we were talking about it, we're thinking of it like, in my mind, it's a sort of fifth or sixth line treatment with similar evidence, and then we think about sort of matching that right patient. So how many patients do we have that are taking all those agents that are actually interested in the procedure that is still newer in terms of evidence, and so it's we know a lot of patients are uncontrolled, still not that many that are, I think it's going to be.
Right. So since I can't see any additional questions, and Lindsay, thanks for answering things in the chat. Can I ask a nephrology type question? So do we have proteinuria or urine ACRs on all these people? And oh, sad. So is that part of a hypertension workup? And should it be? Because I think it should be, number one, and number two, be really lovely, because even if their GFRs are normal, if their urine ACRs are positive, they're at increased risk. It would be lovely to demonstrate that this procedure does or doesn't impact urine ACR in the context of other agents. It's an opportunity missed, I would think. Sheldon?
Absolutely, and that's why it's so important for us to follow these patients, get the proper data before they're treated, and then follow them on afterwards. And trying to put together a Canadian registry to follow these folks afterwards, really look for advice from you, Indira, and how to collect that data, and to try to do it nationally.
Well, I think the data has to come from the hypertension clinics, and it's irrespective of whether they get the procedure or not, otherwise it's biased, right? So if you could have a way to track hypertension totality of treatments and GFRs and urine ACRs and events in all your hypertension clinics, what I think you probably do, because that's what you're tracking, then you could see who gets referred for RDN and then what the outcomes are. So maybe that's something we could talk about offline, because that would be quite easy to set up, I would think, certainly locally in British Columbia.
That would be great, Indira. I've been sadly, Alberta has a better setup for that, and I've been sort of interfacing there with them. But I would love a made in BC solution.
Yeah, we have a good infrastructure for that if we can just coordinate ourselves. So yeah, we could have an offline conversation about that. It would be quite important, especially if we're trying to build integrated business cases for value and things like that.
In terms of the numbers, my sense is, if you look at the hypertension clinics and you say 15% of the patients in hypertension clinics, so it would be several thousand potential patients in BC, several tens of thousands across the country that I think would be considered for RDN. So it's not millions and it's not hundreds of thousands, but it is not a small number either.
Yeah, and I guess that's why all the more reason to have this very sort of restrained or constrained way, like hypertension expert sees, recommends, refers to interventional radiology, who themselves have an expert group, so they are confident, Lindsay, that all of you are up to scratch, and that, that would also be really important if we're going to try and make this accessible to the province.
Totally agree.
Yeah.
That's been our approach. I'm the front man, but I have two of my smarter, more talented younger partners also involved as well. And so, yes, we have lots of talent in BC available to do this that can focus a group on this.
That'd be great. Okay, any other questions for the panel, who now has a fourth person on it, which is great, the doer. It's interesting, like I'm old enough, as many of you know, to have seen renal denervation come in and out of favor. And I think if it's about the technology and the understanding of the pathophysiology better now than we did 10 years ago and 20 years ago, that's great. I still think our due diligence is to do this as a collective in a really organized way. But if you could minimize the drugs that we know don't have any disease modifying properties and only side effects, and that's one of the goals of this, that would be really terrific, right? And then they could just be on the drugs that actually help to do other things as well, if they need them. So that would be really cool. Okay, well, you had over 50 people on a Friday morning at the peak, and so everyone's obviously very interested in this, and we'll have ongoing conversations, no doubt. But thank you very much, all of you, for the preparation and for setting up these clinics and helping us to make sure that we get the right patients to the treatments. Oops, there's one more question that popped in at the last minute. No.
Can I take 1 second to just make
Yes,
a plug
please.
for the chess group here? So we have Canadian Hypertension Specialist Society that we've started, and so we're a group of hypertension specialists across the country, and we do sort of monthly talks on various topics. So these are a couple of our upcoming talks on vaccinations, comparison of hypertension guidelines, and then case discussion. And we've got some YouTube videos coming up and developing a website with a directory. And that's so anybody who wants to be listed on the directory can send me an email. So anybody with an interest in seeing hypertension specific patients, without, whatever, whether you're a member of CHESS or not, whether you're, have any special certification in it, if that's an interest, we can list you on that website. And then you can contact me, and I'll put you in touch to sort of join and get invitations to the meetings if you want to come to any of the sessions.
Great, thank you. Well, thank you, everybody. We're at the bottom of the hour, so happy Friday, and thanks again for all of that great information and thoughtful conversation.